Hello, everyone. Welcome to Chapter 8. In Chapter 8, we're going to be talking about the joints. This chapter is going to be similar to the last chapter that we talked about in Chapter 7, where there's going to be a lot of me going quickly through slides, just telling you that you need to memorize or understand. So there'll be more of a blend of me talking about some stuff, but a lot of the slides will be me guiding you to go away from this video and study those images, study those movements, study whatever it is I'm telling you to study. So it's another odd chapter, but I'll do my best to give you as much information as possible, but the rest, of course, you will have to memorize and study. So joints, we also call them articulations. So those are the sites where two or more bones meet. So we've been talking about the bones, and now we're going to kind of talk about those joints associated with them. We had a few. We mentioned a little bit of this in the previous two chapters. But basically, joints give the skeleton this flexibility and mobility, and really holds the skeleton together. So it helps to create this full skeleton with the ability to move. The two classifications, the first classification is the structural. So we can classify it based on how it's shaped and structured. So there's three types of these structural classifications, and that's fibrous, cartilaginous, and synovial. We talked about these three in the previous two chapters, but we'll mention them again here too. And the second classification is functional. And so there's three types of functional classifications that are based on movement. And so this is synarthrosis, amphithrosis, and diarthrosis. And so it's whether something is immovable, slightly movable, or freely movable. So the structural classifications are more clear-cut. So we won't use these functional classifications as much. So we're going to rely on these, at least in this course. But do note that there are multiple ways that these joints can be classified. But because structural is more clear-cut and we can kind of define them a little better, we'll stick with those. So the fibrous joints, so bones are joined by these dense fibrous connective tissue where there's no joint cavity. And most are immovable when we're talking about these fibrous joints. It really depends on the length of the connective tissue fibers, so there might be some that are movable. This is why I said just a minute ago that we use the structural classification as opposed to whether it can move, because some can, it really depends. So in this case, most are immovable, but there are some that are. So the three types of fibrous joints are sutures, the syndesmoses, and the gomphoses. And so basically sutures, we've mentioned them before, it's that saw-like ridges in the skull. So they're rigid, interlocking joints in the skull, of course. Remember in the last chapter, there's several images for you. We talked about where we needed to memorize each of those sutures. They allow for growth during youth, of course, and they contain these short connective fibers that will allow for expansion. Now, by middle age, the sutures will ossify and fuse. And so these immovable joints join the skull into one unit that protects the brain. So it's closed, it's immovable, and it's referred to as the syndesmoses. So here you go, so an image of that suture, that joint held together. You see they're very saw-like, but that suture line, and by middle age, those are kind of those merge together and become this solid structure. But there is that fibrous connective tissue within that. These syndesmoses, basically bones are connected by ligaments or bands of fibrous tissue. So these fibers vary in length, so movement varies as well. So the short fibers offer little to no movement. One example of this is the inferior tibiofibular joint. And then longer fibers have a larger amount of movement. An example of this is the interosseous membrane connecting the radius and the ulna. And so you'll see some of these as you go through the chapter as well. So this is, of course, that fibrous joint where that joint is held together by a ligament, and you can kind of see these examples here. Here's the fibula, here's the tibia, and that ligament that holds that together. So that's one of those fibrous joints. The gomphoses basically is a peg and socket joint. The only example are the teeth in alveolar sockets. And so this fibrous connection is the periodontal ligament, which basically holds that tooth into its socket. And so you can see that peg in socket image that you have, the root of the tooth, of course, and that periodontal ligament is right there. And it looks like it's like in that socket. Now, the cartilaginous joints, those are bones united by cartilage. Like fibrous joints, they have no joint cavity. They're not highly movable, and there's two types of these, the synchondroses and the symphyses. So the synchondroses basically are a bar or plate of haline cartilage that unites the bones. Most are immovable. Some examples are the temporary epiphyseal plate joints, but after closure, they become this synchondrosis, and basically because they will grow and fuse those joints together. The cartilage of the first rib in the mandible of the sternum is another example of that. So here are those bones that are joined by that haline cartilage. You can see that epiphyseal plate, there's epiphyseal line, and then of course the sternum, you can see that joint between the first rib and the sternum and how that's immovable. The symphyses basically fibrocartilages unites the bones in these types of joints. Haline cartilage is also present as the articular cartilage on bony surfaces. They're slightly movable. Examples are intervertebral joints and the pubic symphysis. And so you see this pubic symphysis, that cartilage there, and then of course these fibrocartilaginous in between these discs with the haline cartilage. Synovial joints, those are bones separated by fluid-filled joint cavity. They are freely movable. It includes almost all limb joints. And there's some characteristics that synovial joints have. They have 6 general features. They have bursae and tendon sheaths associated with them. Stability is influenced by 3 factors. We'll go through those in just a second. They allow several types of movements and are classified into 6 different types. So the general structure of synovial joints have those 6 features that I mentioned in the last slide. They have articular cartilage that consists of haline cartilage covering the ends of bones, and that prevents crushing of bone ends. And then the joint or the synovial cavity has a small fluid-filled potential space that is unique to this particular type of joint, the synovial joints. And the articular joint capsule is 2 layers thick. So the external fibrous layer, dense or regular connective tissue, and then they have an inner synovial membrane, which is loose connective tissue that makes that synovial fluid that I've been mentioning. So the synovial fluid is this viscous, slippery filtrate of plasma and hyaluronic acid. So what it does is it lubricates and nourishes the articular cartilage. And it contains phagocytic cells to remove microbes and debris and keep that area healthy. And so that synovial fluid is healthy, and it can serve its goal, its function. There are different types of reinforcing ligaments. There's capsular, which is the thickened part of this fibrous layer. There's extracapsular, which is outside of the capsule. And there's intracapsular, which is deep to the capsule and covered by the synovial membrane. And then, of course, there's number 6, which is that nerve and the blood vessels. The nerves, of course, as we know, detect pain. We'll talk about the nervous system fairly soon. And then the motor joint position and stretch is going to help serve those functions. The capillary beds supply the filtrate for that synovial fluid. So this is that general structure of that synovial joint. So you see here's a ligament right here. And then, of course, you have this joint cavity, and there's synovial fluid in there. There's, of course, this fibrous layer, and then, of course, the articular cartilage. And then, of course, you have the general bones on each end of that. And so that's that general structure of that synovial joint. Make sure you do know that. Other features of some synovial joints is there's some fatty pads. That's for cushioning between that fibrous layer of that capsule and that synovial membrane or bone. And there's the articular disc, or the meniscus, or the menisci. And that's this fibrocartilage that separates the articular surface to improve the fit of the two bone ends. So it helps stabilize the joint. It helps reduce wear and tear as much as possible. There's bags of this synovial fluid that acts as lubricating ball bearings, essentially. It's not strictly part of the synovial joints, but it is closely associated. So the bursae reduces friction where the ligaments and muscles, skin, tendons, and bones rub together. And then tendon sheaths are just these elongated bursae wrapped completely around tendons subjected to friction. So this is just an image of that bursae and that tendon sheath. So you can kind of see this is that subacromial bursa, this fibrous layer, which is right here. And then, of course, you can see, and of course, this is a frontal section, but the tendon of the long head of the biceps brachii muscle. And then this is that tendon sheath that kind of wraps around that. Still have the articular cartilage, still have the joint cavity, still have the synovial membrane that we talked about before, but this is just showing you that extra tendon sheath and the bursa that is located in those areas. This is just an enlargement of that last image, showing you the bursa rolls, and it lessens that friction, so it can roll back and forth and back and forth. So that fluid-filled sac, it decreases the friction where that ligament or any other structure would rub against that bone, and really helps protect that. So factors influencing the stability of the synovial joints, there's three factors that will sort of influence that stability. One is shape, and it's the shape of the articular surface. Now that's sort of a minor role, but it's the shallow surface is less stable than that ball and socket. And then the ligament number and location, it's a limited role. The more ligaments, the stronger the joint. And then muscle tone, which is the most important. That keeps the tendons taut as they cross joints. So it's extremely important in reinforcing shoulder and knee joints and the arches of foot. So what this tells you is that while there's a lot of factors or several factors that influences the stability of the synovial joint, muscle tone is the most important. What this tells us is we have control over the stability of our joints, that if we work our muscles and strengthen our muscles, we influence positively the stability of our synovial joints. These are just the structural and functional characteristics of the body joints. Make sure you read through that. Of course, it's a larger image in your e-text, so make sure to go through each one of those. Of course, this is continued on to show you the structural and functional characteristics of each of those body joints, so make sure to review those as those are important. So, movements that are allowed by the synovial joints. All muscles attached to bone or connective tissue at no fewer than 2 points. There's the origin, that's sort of the attachment to the immovable bone, and the insertion, which is the attachment to the movable bone. So muscle contraction causes insertion to move towards the origin. Movements occur along this transverse, frontal, or sagittal planes. So the range of motion allowed by the synovial joints, you can have this non-axial, which are just slipping movements. You can have uniaxial, which is the movement in one plane, biaxial, which is the movement in 2 planes, and multiaxial, which is movement around 3 different planes, or all 3 planes, I should say. So the general types of movement are gliding, angular, and rotation. So gliding movements on one flat bone surface glides or slips over another similar surface. Examples of these are the intercarpal joints, the intertarsal joints, so in your hands, in your feet, and between the articular processes of the vertebrae and the vertebral column. So movements, again, allowed by the synovial joints. You can see this gliding movement in the wrist, so you can do that with your hand and see that movement. The angular movements, that's going to increase or decrease the angle between 2 bones. It's the movement along the sagittal plane, And of course, angular movements do include flexion, which it decreases the angle of the joint, and extension, which it increases the angle of the joint. And hyperextension is the movement beyond the anatomical position. So that's going beyond that. So basically, you can see the movements that are allowed here, talking about you've got your flexion, your extension, and then hyperextension if it's too far or beyond. Again, this is flexion, extension, and hyperextension. And then here's another example using different body parts as well. So the flexion there, the extension, and then the hyperextension. Angular movements again, abduction, that's the movement along the frontal plane away from the midline. Adduction is moving along the frontal plane towards the midline. And circumduction, that involves the flexion, the abduction, extension, and adduction of limb. So the limb describes sort of this cone in space. So you see these are the movements that are allowed: abduction, adduction. So you can move that way, and circumduction, that's kind of that cone-like movement of your arm. Rotation, that's turning the bone around along its own axis towards the midline or away from it. Medial, that's rotation toward the midline. Lateral, that's rotation away from the midline. So examples are rotation between the C1 and C2 vertebra, and rotation of the humerus and femur. So you can see here, this is that rotation here. You've got lateral rotation this way, medial rotation this way. Some special movements that do occur, supination and pronation. That's rotation of the radius and ulna. Supination, the palm space anteriorly, the radius and the ulna are parallel. And pronation, the palms face posteriorly, and the radius rotates over the ulna. And we also have dorsiflexion and plantar flexion of the foot. The dorsiflexion is the bending of the foot towards the shin, and the plantar flexion is pointing toes. So you can see some of this pronation and supination here. So pronation this way and supination this way. And then, of course, dorsiflexion up this way and plantar flexion down this way. Inversion and eversion of foot. Inversion, the sole of the foot faces medially, and eversion, the sole of the foot faces laterally. And you also have protraction or retraction. That occurs when the mandible juts out, and retraction when the mandible is pulled towards the neck. So this is that inversion, and this is that eversion. And then the protraction of the mandible coming forward, and then the retraction of the mandible coming back. Elevation and depression of the mandible is another one. So elevation is lifting body parts superiorly, things like shrugging the shoulders. And then depression is lowering the body parts, such as opening the jaw. There's also opposition. That's the movement of the thumb. So basically touching the thumb to the tips of other fingers on the same hand, or any grasping movement that you can think of. And so here's that elevation of the mandible and the depression of the mandible. And then the opposition, touching other fingers or having that grip-like movement. So these are just some of those movements of that synovial joints. We went through most of these, so make sure to know those. Some of the types of synovial joints, there's 6 types of those: plane, hinge, pivot, condylar, saddle, and ball and socket are those. And we'll kind of mention some of these. So basically here you have those 6 types. This is just looking at the plane joint. So you see these flat articular surfaces associate that. It has non-axial movement, so you might have some gliding that occurs. This one, of course, is a hinge joint. You have this uniaxial movement, and you see what that joint actually looks like. Here's the cylinder, here's that trowel, and so it's like a hinge. The pivot joint, you can see it kind of has this little sieve and then this rounded bone, and it has this uniaxial movement as well. The condylar joint, they have this oval articular surfaces, and you see what that movement can look like. It's this biaxial movement. We also have the saddle joint, so you can see this articular surface here and those sort of connecting there, which is also a biaxial movement, this way and this way. The ball and socket joint, of course, probably most familiar with this one when you think about it. This is a multi-axial movement, so you can see the scapula and the humerus and that joint there, the shoulder joints and the hip joints do this type of movement. Again, it's multi-axial, so 3 planes of that movement. So now we're going to talk about that joints in particular. A lot of this is more like the last chapter where I said you just need to know this, but we'll go through these as best as we can. So the synovial joints are diverse. They have general features, but some have these unique special features, ability, and weaknesses too. So there's 5 main synovial joints: the jaw, the shoulder, the elbow, the hip, and the knee. The jaw is the temporomandibular joint specifically. So the TMJ, or the temporomandibular joint, is the jaw joint. It is a modified hinge joint. The mandibular condyle articulates with the temporal bone, and that posterior temporal bone forms this mandibular fossa, while the anterior portion forms the articular tubercle. The articular capsule thickens into this lateral ligament. So there's 2 types of movement here. There's hinge and gliding, and it's most easily dislocated joint in the body. And so this is that jaw joint you can see here. You can see that mandibular fossa here, the articular tubercle here. And if you look, you see the zygomatic process and the infratemporal fossa. And so make sure you understand and know each of these structures here. Here is an enlargement of the sagittal section through that joint, so you can see sort of how that movement is and that structure that's there. And of course, this is the lateral excursion, or the lateral side-to-side movement of the joint of that mandible. So take a look at those movements. You can also do those movements yourself. If you notice a weird sound when I'm talking, it's because when I'm saying these things, I'm also moving that part of my face too. So it's just a habit to move them when I'm talking about them. One of the issues that can occur is dislocation of the TMJ, and that's most common because it's just this shallow socket joint, and it almost always dislocates anteriorly, which causes the mouth to remain open. So to realign, the physician has to push the mandible back into place. Symptoms, of course, are ear and face pain, tender muscles, popping sounds when opening the mouth, joint stiffness, usually caused by, it can cause that grinding teeth, but can also be due to jaw trauma or poor occlusion of teeth. So treatment for grinding teeth includes a bite plate. Relaxing the jaw muscle can help too. Now, the shoulder joint, or the glenohumeral joint, it's the most freely moving joint in the body. The stability is sacrificed for freedom of movement. So the ball and socket joint, it's a large hemispherical head of the humerus, fits in a small, shallow glenoid cavity of the scapula, like a golf ball on a tee. The articular capsule the closing cavity is so thin and loose, so that helps contribute to that freedom of movement. So you can think of your shoulder joint and how much movement you actually have in that. And so the stability of it is sacrificed so that we can move. So that's why there's a lot of shoulder injuries as well. So here's that shoulder joint, making sure you understand each one of those. Remember that tendon sheath we talked about in the last sections, and that fibrous layer, and that subacromial bursa as well. And so that's just that frontal section through that joint. This is a A&P video. I'm not going to play that here, but if you go into the PowerPoints that I have loaded with you where this video is located, you can watch these flicks there. But that's that shoulder joint there. You see the humerus here, and basically you can see that articular cartilage and that synovial cavity that's there. The shoulder joint, again, this glenoid labrum, this fibrocartilaginous rim around that glenoid cavity, it helps add depth to the shallow cavity, and it still only holds 1/3 of the head of the humerus. It's reinforcing ligaments. It's primary on the anterior aspect, and the coracohumeral ligament, it helps support the weight of the upper limb. And there's 3 glenohumeral ligaments. They shrink on the anterior capsule but are weak support. So again, that's that shoulder joint showing you those important ligaments that I was mentioning before. So make sure you understand each part of these as well. Oops. Again, the lateral view of that socket and showing you that glenoid labrum and that glenohumeral ligaments. So make sure that you're looking through those. Reinforcing muscle tendons sort of contribute most to this joint stability. So the tendon of the long head of the biceps brachii muscle is the super stabilizer. And so 4 rotator cuff tendons encircle the shoulder joint. And these, of course, are those tendons that surround that, enclose that joint. And so here's that shoulder joint. Looking at that posterior view, you can see that rotator cuff muscles that's been cut so that you can see the head of the humerus and all of that that's inside there on a cadaver. One thing with regards to issues with the shoulder joint is shoulder dislocation. Very common because of the mobility. Remember, we said we sacrifice stability for mobility. So there can be a lot of injury. So structures that reinforcing this joint are the weakest anteriorly and inferiorly. So the head of the humerus can easily dislocate forward and downward. The glenoid cavity provides poor support when the humerus is located laterally and abducted. So an example is when a football player uses the arm to tackle opponent. It blows to the top and the back of the shoulder can also cause dislocations. Again, this is a video of the rotator cuff muscles. You can look at those and watch that movement in your PowerPoint. Same for this one, and here, and here, and here as well. The elbow joint, the humerus articulates with the radius and ulna. So the hinge joint formed primarily from the trochlear notch of the ulna, articulating with the trochlea of the humerus. So this allows for flexion and extension only. The annular ligament surrounds the head of the radius, and then 2 capsular ligaments restrict side-to-side movements. And that's the ulnar collateral ligament and the radial collateral ligament. So again, open your PowerPoints that are provided for you so that you can see this video of how that movement occurs. So this is the elbow joint. Again, this is the humerus here, but you can see the trochlea, the bursa again here, and of course you can see the tendons that are there, some fat pads that are associated with that as you look through, and then the ulna and of course the humerus. And of course this is the lateral view of the right elbow joint, seeing those important ligaments that are there that allows for that movement. And here it is under a cadaver photo, the medial view of the right elbow and what that looks like. There's that annular ligament there, and here's that ulnar collateral ligament there. Again, here is a video that shows you that movement, making sure to utilize that in your PowerPoint. The elbow joint, the medial view of that elbow, this is that annular ligament again. This is that articular capsule here. This is that ulnar collateral ligament that you see here. There's the ulna and the humerus as well. Again, making sure to pull up your PowerPoint when you're studying this to watch the video of that movement. The coxal joint or the hip joint, that is a ball and socket joint. Its large spherical head of the femur articulates with deep cup, the acetabulum. Basically, a good range of motion, but limited by the deep socket. the articular labrum, the rim of the fibrocartilage that enhances the depth of the socket, the hip, and dislocations are rare. So the hip joint, you can kind of see the frontal section through the right of the hip joint. You have the femur here, and then, of course, you have the coxal bone or the hip here. And then you see that articular cartilage, you see that vestibular lacrium, and, of course, the synovial cavity and the articular capsule. So making sure to look and understand those. Again, like I said with the previous videos, make sure that you go into the PowerPoint and watch the movement so you can see that movement for yourself. This is, of course, a cadaver picture of the hip joint. So this is the head of the femur. This is that articular capsule that has been cut so that you can see inside of where the femur is. This is that synovial membrane. And then here's that acetabular labrum that we talked about. So again, continuing on with the coxal joint, there are some reinforcing ligaments, the iliofemoral ligament, the pubofemoral ligament, the isofemoral ligament, and the ligament of the head of the femur. That is also called the ligamentum teres. It's basically slack during most hip movements, so it's not really important in stabilizing, but it does contain artery that supplies that head of that femur. So the greatest stability comes from the deep ball and socket joint. And so you can see here is that iliofemoral ligament and the ischiofemoral ligament. So make sure you take a look at each of those. And here is the different view so that you can see not only the iliofemoral ligament, but also the pubofemoral ligament. Again, like I said with the previous videos, you can go in and watch these videos in the PowerPoint. So the knee joint is the largest, most complex joint of the body. It consists of 3 joints surrounded by single cavity. The femor-patellar joint, that's a plain joint. It allows a gliding motion during knee flexion. The lateral joint and the medial joint. So here is that knee joint. Of course, it's showing you the ligaments that are associated with that, the posterior cruciate ligament and the anterior cruciate ligament, and the subcutaneous patellar bursa, which is really important in this sort of video here, or image here. And of course, this is the superior view of the right tibia, showing the meniscus, and menisci, I should say, and the cruciate ligaments. So here's that anterior cruciate ligament. Here's that lateral meniscus, and then the articular cartilage. And then, of course, here is that posterior cruciate ligament and that medial meniscus. Again, like I said with the previous videos, make sure to go in and watch the knee movement and how that works in the PowerPoint that's provided. So the joint capsule is thin and absent anteriorly. So the anteriorly, the quadriceps tendon gives rise to 3 bound ligaments that run from the patella to the tibia. So the medial and lateral patellar reticula is that flank the patellar ligament. So doctors tap that patellar ligament to test for that knee jerk reflex. And at least 12 bursa are associated with the knee joint. And so here you see there's the patella, and there's the tendon for the quadriceps femoris muscle. And what you see here is that fibular collateral ligament, that lateral patellar, that patellar ligament, the tibial collateral ligament, and the medial patellar reticulum. So the capsular, extracapsular, and intracapsular ligaments act to stabilize the knee joint. And then the capsular and the extracapsular ligaments help to prevent the hyperextension of the knee. So the fibular and tibial collateral ligaments, they prevent the rotation when the knee is extended. The oblique popliteal ligament stabilizes the posterior knee joint, and the acute popliteal ligament reinforces the joint capsule posteriorly. And so here's that posterior view of the joint capsule showing you each of these ligaments. Here's that tendon of that muscle, basically. Here you see the popliteus muscle that's been cut to show that the inside of all of these ligaments that you see here. So make sure that you understand and look for each of these ligaments there. To help prevent the anterior-posterior displacement, we have something called the anterior cruciate ligament, that's the ACL, that attaches to the anterior tibia, and it prevents forward sliding of the tibia and stops hyperflexion of the knee. And there's also the posterior cruciate ligament, the PCL, and it attaches to the posterior tibia and prevents backward sliding of the tibia and forward sliding of the femur. And so that's your knee joint here that you're seeing here. And basically what you see, this is the posterior cruciate ligament, and this is the anterior cruciate ligament, the ACL. As you know, that there's a lot of injuries in sports, and it's injury to the ACL. And so you can see you can see where that's located, and probably know a lot of people with those injuries. Again, with this video, make sure that you are opening the PowerPoint so you can view the rotating knee. This is the cadaver version of the knee joint, so you can see what that looks like. There's the patella here, and there's the medial femoral condyle. And then, of course, this is right here, that ACL, that ligament that we're talking about. And that's it for this chapter. Make sure that there's a ton of those movement videos, so do make sure that you go in and look at those videos to see how that movement progresses. If you have questions, please let me know. I'm always happy to help. Make sure to utilize all the resources that I have for you. But if you have questions, please feel free to reach out. I'm always happy to help, and I hope everyone has a wonderful day.